Hello, everyone. Welcome to the last session of the conference before the conclusion. This is the autonomic effects of trigeminal nerve injury, presented by Dr. Brown. My name is Ann Simnecki. I'm a third generational person with trigeminal neuralgia, and I'll be your moderator today. I hope by this time you all know the drill, that you can put your questions in the Q&A section, and we'll try and get to as many of them as we can before the end of the session at 6:30. I'll do a brief introduction of Dr. Brown. He is an assistant clinical professor at NYU Winthrop Long Island School of Medicine and director of their CyberKnife Neurosurgery Center. He served unselfishly for the past 6 years as the chair of our medical advisory board here at the FPA. And I don't have to tell you how many books or articles or presentations Dr. Brown has done. I'm sure you all know of them. But what I do want to tell you is how he serves his patients. And he does that with honor and integrity. And the thing I've learned about Dr. Brown while working on the first edition of the book with him, and by the way, we're working on a second edition that will be out next October, is he never gives up on a patient. And his favorite expression is, "I can help you. There's still a way. We'll find something." And I think for patients like us, that's just a wonderful thing to hear. So without any further ado, I'm going to turn this over to Dr. Brown, who's going to talk about the autonomic effects of trigeminal nerve injury.
Thank you so much, Ann. I'm honored by your heartfelt presentation. I feel really good, and I hope at the end of this talk, some of you may feel a little good too, that I've been able to explain things to you. So can I see my slides? Some miracle person will pull it up. There we go. Next slide. Hit next. Any chance something will happen? Okay. So I got into this idea of autonomic changes in the trigeminal nerve when I started to do balloon compression rhizotomies, which I'll talk a little bit about, for trigeminal neuralgia. And as the patient was waking up from anesthesia, we got into the habit of opening their eye on the side of the balloon compression to see if it had become red and teary. And indeed, that would be the indication that the trigeminal nerve had been injured. One other thing could happen, and that is at the time of squeezing the trigeminal nerve, I discovered consistently that the heart rate would slow down. In fact, it was even possible to stop the heart briefly before there was a reflex rapid heartbeat. So the trigeminal nerve, when it's injured in any way, is intimately involved with what I will call the wiring system of the human body. So this first became evident with this article in 1908, so 100 years ago. Someone described what's called the oculocardiac reflex. And eye surgeons know about this because when they rub the eyeball or injure the eyeball, it will trigger a slowing of the heart rate. And the way it does that is information comes in to the trigeminal nerve. It's projected to the brainstem, to another nucleus, and onto the nerve that we'll talk about called the vagus nerve, and then to the heart to slow it down. So is that the only thing the trigeminal nerve can do? No, there are a whole gangland of things that the trigeminal nerve is mixed up in. Next slide. I'm going to mention this thing called SUNCT. I am not an expert in SUNCT. I have not ever diagnosed a patient with SUNCT. What does that stand for? Short, lasting, unilateral, one-sided, neuralgiform, some kind of nerve injury, headache, attacks with conjunctival injection, the red eye, and tearing. There's SUNCT 1 and SUNCT 2, and SUNA but let's just say it's trigeminal nerve symptoms that have autonomic effects. Question, is this truly different from trigeminal neuropathic pain? Keep it in mind. Next slide. So, a little bit of medical student lectures here. What's autonomic? Autonomic means auto functioning. It's originally a term that was autonomical, self-governing. It means it refers to those involuntary functions of the nervous system, which are things we can't control. It's the working elements of the internal organs of our body, such as the muscles of the heart, the blood vessels, the stomach function, the intestines, the breathing functions, the sweat glands, the salivary glands, the digestion system, the relaxation ability of our body, and instinctual emergency reactions to something that scares the hell out of you or can injure you. Next slide. Okay, so the autonomic system is the wiring of your body's internal operating system. And it's the brainstem that's the processor. So you all have phones, they have wires. The processor is that fancy thing that's there. Oh, I can't point. And it's the brainstem that does the processing. And then there's the wires that project things that happen throughout the rest of the body. Next slide. Principle number 1, anything that irritates or injures the trigeminal nerve branches or the ganglion or what's called the nucleus of the trigeminal nerve will have some kind of autonomic consequence. Why is that? Because the trigeminal nerve is intimately wired into the autonomic nervous system within the brainstem. And it's the brainstem that controls the unconscious activity of the body. So, next slide. Principle 2, the more intense the injury to the trigeminal system, the more widespread these autonomic effects are. And they can even go down to your digestive system. The closer to the center of the trigeminal system, the trigeminal nucleus deep in the brainstem, that an injury occurs, the more the effect is amplified. So a little scratch in your face can have autonomic effects, but something that injures the nerve right up against the brainstem will have more widespread effects. Next slide. If the operating system is injured, then things go haywire. I looked up the meaning of the word haywire. Haywire is the very thin wire that's used to bale hay in the fields. And if you just leave it alone, it gets incredibly tangled up and it doesn't work. You don't want that. Next slide. So in the brainstem is what's called the nucleus of the trigeminal nerve. What's a nucleus? It's a collection of cell bodies, the essential part of the nerve, that these are organized according to specific functions. There are sensory functions, there are motor functions, there are special sensory functions. And in the nucleus, these cell bodies are all organized together. So there's one nucleus for sensory involvement. There's one nucleus for motor function. The trigeminal nerve does have motor function. That goes to the chewing muscle, the masseter muscle, the big thick muscle here, and it goes to your eustachian tube. It controls the opening and closing of the eustachian tube. So if you go up and down on a plane, you can open and close your eustachian tube so your ear doesn't pop. And it's the trigeminal nerve that does that. And of course, it controls pain and sensation that comes from the face. Next slide. Next. So the trigeminal nucleus projects, sends fibers to what's called the solitary nucleus, which is in the brainstem. And the solitary nucleus sends fibers to what's called the vagus nerve, which is the 10th cranial nerve. It's called the vagus nerve because it has many, many vague effects when it's stimulated. It can cause what are called sympathetic effects or parasympathetic effects. Next slide. So what are sympathetic effects? Reading off my slide. So it deals with the things that make you alert, or what's called the fight and flight response. Something hurts your body, something terrifies you. It stimulates the sympathetic system. Your eyes' pupils dilate so you can see better. It increases your heart rate so you can run or fight better. It diverts energy away from your digestive system because you can't be bothered doing digestion. You need your energy elsewhere. And it actually activates the energy stores that are held in your liver so you can make use of extra energy. All that is from activation by epinephrine. You've heard of epinephrine that comes out of the sympathetic nervous system. Believe it or not, that's still involved with the trigeminal nerve. Next. Next slide. Then there's the parasympathetic nervous system. It does the opposite of what the sympathetic nervous system. It does feed and breed. It does things that help you to rest and digest. So it can slow your heartbeat down to allow you to relax. It can, reading this, constrict your pupils. That's it. So it's easier to fall asleep at night. What else does it do? It increases your digestion. Anything that will allow you to relax. The opposite of the sympathetic system. Next slide. What's going on in your body is that there's a constant equipoise between what's going on in the sympathetic system and what's going on in the parasympathetic system. And if you injure the trigeminal nerve, next slide, you upset that equipoise. The thing is, it's hard to predict what exactly is going to happen because the trigeminal nerve, when it's injured, can give a mixed response. It can stimulate one system, it can inhibit one system. And it depends upon the nature of whatever's injuring the nerve and the severity of what's injuring the nerve as to what happens. It's not predictable easily. However, next slide. Next. So let's think of the brain as a highly complex electrical system. Oh, give me back a slide. Go back. So the wiring moves electrons. It can do that with high frequency, meaning more rapid repetition of electron pushes. It can mean high voltage, meaning how hard the electrons are being pushed each time. And it can mean high current, meaning what's the total volume of electrons that are being pushed. And by varying those elements of electricity, it will cause different effects to the trigeminal nerve. Next slide. You can go to the next slide. So what was discovered in research is that if you stimulate close to the brainstem with low frequency stimulation, meaning 40 times a second, as opposed to 100 times a second, you can stop the heart, you can slow the heart. If you stimulate at high frequency, you will speed up the heart. It's a varying response. The thing is, if you do something that squeezes the trigeminal nerve, as we do with balloon compression, next slide. Next slide. Can we go to the next one? Am I frozen? No. Okay, we can go to this one. We went to. So this is a picture of what happens with balloon compression. It's actually showing on the top left a view from inside the head, not an alive person, in a cadaver, where the white arrow points to the balloon and the blue arrow points to the trigeminal nerve as it comes into the brainstem. This balloon is squeezing the trigeminal nerve. There was some confusion. Balloon compression doesn't do anything in Meckel's cave. It does it right up against the nerve. And when it squeezes the nerve, it's a giant whack. And you get an outpouring of a varied response of inhibition and stimulation, which can speed up the heart, slow the heart. It can first slow the heart, then speed up the heart. And it all varies on the severity of the injury. Next slide. So disease can also injure the trigeminal nerve. Inflammation can injure the trigeminal nerve. And it doesn't have to be from a vascular compression. It can be for some form of inflammation. Now, inflammation is the body's way of clearing out things that are injuring a nerve. But if inflammation continues and it persists, it can be a problem in and of itself. Because inflammation is a release of irritating chemicals that allows veins and vessels to dilate. And when they dilate, they take away injured material. And that's great. It brings more blood flow and increases the health of the area that's injured. But if it continues, it's abnormal and it affects the nerve and causes chronic pain. And suspicion is that there is a component of that in trigeminal neuropathic pain. There's been some recent research to say that there is inflammation involved in trigeminal neuropathic pain. Next slide. Next slide. Can you give me the next slide? So the question I raised at the beginning is this short-lasting unilateral neuralgiform headache with conjunctival changes and tearing, is that really a different disease? And my answer is, it's a part of trigeminal neuropathic injury, because these are autonomic effects of injury to the trigeminal nerve being expressed. And they could well be mixed in with a patient who has trigeminal neuropathic pain, which could be caused by vascular compression, contact, by an artery or a vein. And before one gets waylaid with the diagnosis of SUNCT, you have to be evaluated, I believe, just as carefully as if you had what people think is trigeminal neuralgia, but is actually probably in everybody a more complicated entity. In my patients, I have them fill out something called the McGill Pain Questionnaire, and it lists 75 different words to describe a patient's pain. And yes, with what's known usually as trigeminal neuralgia, they'll say the pain is stabbing, sharp. They may even use the word lancinating, only because it's suggested. People don't really use that word much anymore. But they will also have other elements to the pain that are not normally associated with trigeminal neuralgia. There may be aching quality to it. There may be pressing quality to it. And in the majority of patients, if you ask, they'll come up with those words. So even the most classical, quote, trigeminal neuralgia patients have a more complex underlying element to their pain. So next slide. Is there a next slide? I think that's what I just said. Trigeminal neuralgia is what I describe as trigeminal neuropathic pain. And we may not be attuned to the other effects that are happening with this trigeminal nerve injury. And the point of my talk is that perhaps those of you with trigeminal neuropathic pain and other things that are being ignored can understand that the trigeminal nerve is not simple. Injury to the trigeminal nerve is not simple. It's not just a stab here and nothing more. It's intimately involved with the inner workings of the body. And I think we should be more attuned to all those other inner workings in the evaluation of patients with trigeminal neuropathic pain, which is what I prefer to call those of you out there listening. Thank you.
Thank you, Dr. Brown. That was really interesting, and it really raised a question in my mind that I'm going to ask you in a few minutes. But one of the questions that came up in the chat was, does this apply only to trigeminal neuralgia, or does it apply to the other cranial nerve neuralgias, like glossopharyngeal and...
Well, don't get me going about glossopharyngeal neuralgia easily, because I do not believe that glossopharyngeal neuralgia is a proper diagnosis. Even Dr. Janetta, when he first described the microvascular decompression for what he called vagoglosopharyngeal neuralgia, meaning if an artery is going to affect the glossopharyngeal nerve, right next to the glossopharyngeal nerve is a web of fibers composing the vagus nerve. So there isn't really a thing called glossopharyngeal neuralgia. It's called vagoglosopharyngeal neuralgia. And the answer to your question, which is perfect, is yes, it does apply to other cranial nerve neuralgias, because glossopharyngeal neuralgia is vagal glossopharyngeal neuralgia. So amongst other things that occur with vagoglosopharyngeal neuralgia is something called dysphonia, by the way, because a branch of the vagus nerve goes to the recurrent laryngeal nerve, which controls your vocal cord, and people can get hoarse from vagoglosopharyngeal neuralgia, and that's little known cause of hoarseness, which is not usually looked into. No one thinks automatically of looking at the brain when someone is hoarse, but indeed, hoarseness can come from the brain.
Mhm.
So good question.
Thank you. Another question is, can one find relief with an external vagus nerve stimulator?
What can we do with it?
Get relief.
From trigeminal neuralgia?
Right.
I'm not sure. I've never done it.
Okay.
It's used for epilepsy. It's used. There have been studies recently about dramatic effects of the vagus nerve stimulation, because it's called the vagus nerve because it's so vague in its effect. But I don't think anyone has tried treating trigeminal neuralgia, neuropathic pain, with vagal nerve stimulation, to my knowledge.
Okay.
Is it crazy? It's not crazy.
Mhm.
It's not crazy. But I think there's at least one neurosurgeon who's looking into some unknown effects of vagal stimulation, benefits of vagal stimulation. So it's possible, but I don't believe anyone's tried it.
Okay. So another question is, people are talking, a few people spoke in the Q&A about blurry vision. Is that related to trigeminal neuralgia? Blurry vision that comes and goes? Excuse me.
Well, the optic nerve, which controls, is not affected by trigeminal neuralgia. However, if the trigeminal neuralgia is affecting the pupillary function by dilating it or constricting it, I suppose it could, on one side, affect your vision. But it's not because of an injury to the optic nerve system.
Mm-hmm. Could it be from the medication?
What's that?
Could it be from some of the medication, the blurry vision?
Oh, yes, most definitely. If you take too much gabapentin, your whole nervous system slows down. So it's like drinking too much. You'll just not be able to focus. So yes, certainly, if you're on too much of gabapentin or oxcarbazepine, it can affect your eye movements and thus your vision. That is true.
Okay.
Certainly it can. It affects your coordination. It affects your mentation. It affects your balance.
Mm-hmm.
Certainly can affect your eye movements. Yes.
So I'm going to ask my question now, because I'm thinking back a few years when I remembered, my mother had Crohn's disease in addition to trigeminal neuralgia. And I remember reading in a patient packet insert once that Tegretol could cause Crohn's disease. And then I never saw it again. But I wonder if it was causing all those digestive problems wasn't the autonomic effects of her trigeminal neuralgia and not the medication. Do you think that could be possible?
Fascinating. That's what I'm saying. We don't focus normally on all these other elements in evaluating the trigeminal pain. Even if I go see a new patient, I'll check their sensation, I'll talk to them about their face, but we're not focusing on all these other things. I think we should. It's a really good thought.
Mm-hmm.
Again, the trigeminal, I don't think we've really mined all the effects of trigeminal nerve injury in patients with trigeminal neuralgia, neuropathic pain.
I bet
And
not.
so, again, that's the point. I'm just saying it aloud to myself so that we can begin to look for other things than just you get a stab in your face. I think it's important.
And then we had some questions about what's broadly called dysautonomia. And is that related to trigeminal neuropathic pain?
What dysautonomia?
Is that
Any
related?
Kind of autonomic changes are, by definition, dysautonomic changes.
Okay.
There are people that have cardiac dysautonomia and they faint or their blood pressure drops when they stand up. Is this a result of trigeminal nerve injury? I have no idea. But usually the people with dysautonomia are evaluated by special cardiologists who do tests of the heart function. But the trigeminal nerve has an effect on the heart. So it's worth looking into if someone has that.
Yeah, I actually know someone who was taken to Princeton Hospital, the local community hospital, and he had a heart attack, like heart attack symptoms, or maybe even a heart attack after having a terrible trigeminal neuralgia attack. And in fact, people might know him. He was the support group leader in Princeton for a long time.
Well, a trigeminal neuralgia injury will raise your blood pressure. Dr. William Sweet, who designed radiofrequency rhizotomy as a treatment for trigeminal neuralgia, described something called dental chair stroke, and that people who have sudden severe trigeminal pain will have such an increase in their blood pressure that they can have a stroke from that. Or one can get a stroke from injuring the trigeminal nerve with a radiofrequency needle. It raises the blood pressure. And that was the early confusion when I first learned that balloon compression lowers the blood pressure. Nobody would have believed me when I presented it to my audience of neurosurgeons, because they all said, oh, we know that injuring the trigeminal nerve with radiofrequency rhizotomy raises the blood pressure. So you're not, how is it you're talking about lowering the blood pressure? And again, it's this mixture of effects on the trigeminal nerve, but definitely if you heat it, the blood pressure will go up. And if you squeeze it, the blood pressure will drop, but then there'll be a reflex where it goes up again. The point again is that this is not a simple system, and we need to be aware and look for it as physicians. And you as the patients might think a little bit about these other things that you're ignoring and bring them up when you talk to your neurosurgeon, who probably think you're crazy, but you can quote me.
Yeah, and that's actually a question that came up from Kathy Kemkin, again, one of our support group leaders, who is asking, how do we convey this to our doctors to have them look beyond what's on the surface in the 5 minutes they spend with us?
Well, you're now all experts. You can listen to my lecture again, and you can give your doctor a lecture as to what the possibilities are. That's the best I can come up with.
Yeah. Well, a number of people commented that this talk explained a lot of their symptoms.
Really?
Yes.
I'd love to hear. Please send me stories. I want to use this for my own edification.
Oh, good, good.
You don't have to give me your names, just your story. I'd be thrilled to see them.
Okay. And we have lots of thank yous. Oh, let me see.
You're welcome. I thought I would bore you. I hope I didn't bore you all.
Somebody said, is numbness after an MVD considered nerve trauma? I guess it would be nerve injury if something else happened. It's nerve trauma,
nerve injury.
Yeah.
That happens. But it may not be permanent. After an MVD, manipulation of the nerve may cause temporary numbness from which you can recover. There are situations where, because of coagulation of a vein, for example, the coagulation is like a radiofrequency injury to the nerve, and it can cause permanent numbness. My hope is that if someone has numbness after an MVD, that's not the cause. You don't want permanent anything. But use of coagulation near the trigeminal nerve can cause permanent numbness. One has to be careful about that, which is why when I do an MVD, if I see a vein as the cause, my first instinct is to mobilize that vein off of the nerve rather than to coagulate and cut it. For two reasons. One is because there's a risk of injuring the trigeminal nerve from that coagulation. You try to protect the nerve whenever you do it. And secondly, if you coagulate and cut one vein, new veins can form. New arteries don't form, but new veins can, and they can be a later cause of recurrent pain. So I don't like to coagulate and cut. I don't like to glue. We talked about that,
Mhm,
but that's perhaps my bias.
mhm. We have another question. Can I keep
Mhm.
going? I'm frozen, but I can keep talking. Somebody
Yep.
is asking, what's the correlation between MS and trigeminal neuralgia? This is a young patient with idiopathic trigeminal neuralgia, and she was told that MS could be a possibility as she gets older. I guess I always thought it was the other way around.
In my experience, I see trigeminal neuralgia in patients with multiple sclerosis. I have not, in my experience, seen patients with trigeminal neuralgia who then go on to develop multiple sclerosis the other way around.
Yeah,
And
that's
the
what I
reason
thought.
is to get trigeminal neuralgia from multiple sclerosis is the sclerosis is a sclerotic injury to the white matter in the brain stem. And white matter is myelin. It's the insulation on nerves. And because the trigeminal nerve has a huge amount of insulation to rapidly transmit sensation from a touch in the face to the brain, it's prone in its system to developing sclerotic plaques from the multiple sclerosis more than other areas.
Mhm.
So, yes, it's true that patients with multiple sclerosis often will develop plaques in the trigeminal system.
Mhm.
But it's not true that because you have trigeminal neuralgia, you're more likely to get multiple sclerosis, in my experience.
Okay.
That's a terrible thing to tell someone, to worry about that for the rest
I
of their
know.
life.
I know. Like TN's not enough, right?
Yeah.
Um, let's see. Here's somebody that says that she was taking topramate
Yeah.
for her facial pain, but it gave her very bad side effects regarding her eyes. She doesn't say what they were. And is there any medication similar to topramate that wouldn't affect her eyes?
That won't affect her eyes. No,
Right.
as I said, these medicines, which are seizure medicines, slow down the function of the whole brain, the whole nervous system.
Mhm.
And so they can affect your ability to move your eyes appropriately and give you double vision and trouble with your vision, blurry vision because of it. So it's too much medicine. The next step would be to go to Dr. Leake's lecture and see what else is available, but the most likely thing is low-dose naltrexone.
Mhm.
But I refer you to Dr. Leake's lecture from earlier today about how to move off of Topamax and on to low-dose naltrexone as an option.
Yeah, and that lecture was so packed with information.
That's
I would say watch it 2 or 3 times.
more than that. Even I have to watch it over and over again.
Yeah.
It's an introduction to something you have to study. But you as a patient can't really study it. You've got to get your doctor to study it. And
Right.
that's hard because the question I saw was, well, is there a neurologist near whatever town? And the answer is there's nobody like Dr. Leake anywhere, which is why I recruited him to join the medical
Right.
advisory board.
He's special. He's listening. He's on right
Large
now too. So he's hearing you.
unless he educates them who can do this. It's not like Dr. Linsky saying you have to be trained by Dr. Janetta to be a good neurosurgeon in trigeminal neuralgia, but Dr. Leake doesn't seem to have trained a gathering of neurologists, unfortunately. But you
Right.
have to be somewhat of a student of what he has to say
Mm-hmm.
to be able to treat trigeminal neuralgia. So
Okay.
that's a tough one. I don't know any neurologists who are as knowledgeable or even close to him.
Mm-hmm. So I'm going to answer a question myself. This is Eric Mello has asked a question about the possibility of barometric pressure creating or worsening flare-ups. And Eric, if you have the book, 21st Century Guide, there's a chapter in there about that. And if you don't have the book, contact me and I will send you a copy of that chapter. You can email me. It's my name, asimnecki@gmail.com. And now Monica Williams is going to ask you a question that's going to take up the rest of this session. And she says, why don't you like the glue?
Why don't I like what?
The glue.
The glue. Okay, so this didn't get very far in my discussion with Dr. Zimmerman. He says, we ended it was, do I not use this thrombin soaked gel foam? And the answer is I use thrombin soaked gel foam, but I wash it out when I'm done. I don't leave it. So I don't like to leave things that are other chemicals in the brain. And so I know he says it's nothing, and it may be nothing, but Teflon has been used for 30 or 40 years, and I personally have not had to operate on someone with an enlarging granuloma affecting the trigeminal nerve in any of my patients, at least. And I don't think I've seen any patients come to me where I had to remove such a thing. So it's extraordinarily rare. So it's a pretty good thing. And the only thing is, for a pretty good thing, I always say less is more. So I try to use the smallest amount that I can of the Teflon. Somebody has suggested that we soak the Teflon in a steroid solution to reduce inflammation. I don't know if that will help. I'm certainly one who has tried new things, and that's why I said to Dr. Zimmerman, let's see the results of long-term multiple doctors using a glue method to see if it's a better method. Maybe it is. I'm open. Let's give it a chance in good hands. And certainly his hands and Dr. Linsky hands are quite good. Now you're frozen.
I've been frozen. Can you hear me?
Yeah.
Okay. Okay, somebody commented.
So why don't I use glue? I can just think, for example, in the last patient I operated, there was no room to glue anything away. The artery that I saw was sandwiched between two veins holding that artery against the trigeminal nerve, and there was no way I was going to be able to glue it anywhere. So it was very close to what's called the fourth cranial nerve, which is involved with moving eyes. It's a very tight area, and I personally prefer to do the least amount of manipulation I can, and rather than try to sling that artery off into some hinterland, I would rather just put in a tiny piece of Teflon and say, yes, I've done my job. But that's my philosophy. Less is more.
Less is more.
And that's me.
Mm-hmm.
And so there will be other people with other opinions, and these are very good surgeons with other opinions, but that's the way I'm going to continue. Do the least amount possible.
I'm just scrolling through questions now because they're coming in as we're talking.
If you want me to answer some other questions that came up in Q&A, Dr. Linsky mentioned negative explorations. I'm not one to say, I'm going to explore your trigeminal nerve. If I do an MRI and don't see a cause, meaning a vascular contact, I'm not going to do a microvascular decompression. Now, I know Dr. Linsky says that there can be tiny, tiny little vessels underneath the cerebellum ala. I can see, when I review an MRI, not only do I look at it myself, I discuss it with a neuroradiologist, and as much as possible, I use the same neuroradiologist all the time who does the study, interprets the study, and talks to me, and we go over it together to interpret that study. Very often, patients will come to me and say, well, I had a negative MRI, but I still have trigeminal neuropathic pain. And just because a radiologist says it's negative does not mean it's negative. I have to evaluate that myself. And if I do a careful evaluation and I see a cause for the trigeminal neuralgia that I plan on operating on, personally, I don't feel the need to, quote, explore. I will go after what I see, and I will not muck around looking for anything else, because these MRIs that I review with my radiologist, I think are high quality. And I know Dr. Linsky will disagree and say it's not good enough, but I think it's pretty good, and it's not worth the effort for my potentially injuring the nerve by looking for things that I couldn't see on a very carefully done MRI. And you're giving me a chance to talk about all the things that bother me. So I'm.
Oh, go ahead, keep going. Keep going.
What else do I want to talk about? Removing Teflon. I want to reiterate what Dr. Linsky talked about. If in doing the reoperation, the purpose of the operation is not to remove the Teflon, the only reason that I will reoperate is if I see another vessel causing the trigeminal neuropathic pain. And the purpose of the operation is to move that vessel off of the nerve, not necessarily to remove the Teflon. If the Teflon's in the way, I will remove the Teflon that's in my way of getting to that nerve. But I will not, simply because it's there, say I need to remove the Teflon, because as Dr. Linsky also said, it's an inert object. It's not causing pounding injury to the nerve. And along those lines, it still is a foreign body. And if it's a large piece of Teflon, the body will try to wall it off by forming a very thin capsule around it, paper thin capsule, which is what enhances when the radiologists say, oh, it's enhancing. If they give contrast, you'll see the tiny, tiny little thin capsule around a large piece of Teflon. But that's, in my judgment, not a cause for trigeminal neuralgia. The vessels in it are tiny, tiny, and I don't believe they have to be moved off the nerve. It's usually a vein that may be new, or a vein that was missed, or a part of an artery that is that was not completely decompressed, but it's not the Teflon. And so in reoperating, which I find myself doing just like Dr. Linsky more and more, the goal is to move an artery over a vein off of the nerve, not to move the Teflon off of the nerve. And why I'm doing it more and more, it's just the way it is. I don't believe it's because there are bad neurosurgeons out there. It's just the nature of patients being referred to doctors like Dr. Linsky and Zimmerman and myself.
Is the Teflon even removable without damaging the nerve? I mean, doesn't it fibrose and attach?
Yes, if it's a large piece of Teflon, there's a risk of injuring the trigeminal nerve when you manipulate it off, which is why I don't like to do it.
That's what I thought.
It does cause some inflammation. I don't believe that inflammation is what's causing trigeminal nerve pain, but it sticks sometimes. It mostly sticks if it's a large piece. And one thing that I've learned is to put in as little Teflon as possible. There's no advantage to putting in more and more. And that's what causes the stickiness.
Yeah.
Also makes it difficult to image the trigeminal nerve. Dr. Linsky briefly mentioned a way to do that. I didn't catch what he said, if there's Teflon there, but it is difficult, and most often the neuroradiologist is going to have a lot of trouble evaluating the trigeminal nerve after surgery.
For you now.
So again, reoperation, the reason for reoperation is because there's another vessel of some kind against the nerve. And so if I don't see another vessel, I'm not going to reoperate and do another microvascular decompression. And then the other point, if the nature of the pain is it's a constant burning pain and not an intermittent stabbing pain, I don't want to do something to injure the nerve anymore, because the nerve is expressed nerve injury pain. And then we have to move to different forms of what's called neuromodulation, modulate the function of the nerve. And I believe Dr. Palitzis talked about that earlier today. But it's the use of electronics to modulate the function of the nerve, either over the peripheral branches of the trigeminal nerve or at the level of the thalamus by stimulating the cortex of the brain. But in terms of constant numbness, I'm not going to do anything that's going to make them more numb. And just a little bit isn't going to work. Just don't do it. So if someone... Go ahead.
I think we have time for one more question. And I was hoping you could help someone who's had TN for about a year now. She knows she has an arterial compression, and she wants to know what the likely success rate of an MVD is for her. And I assume she means done with the right doctor.
The quoted likelihood of long-term success is 90%. This is a good system, a good place to be.
Yeah.
This is a really good place to be. So choose your doctor wisely. I would say, if you're going to have a microvascular decompression, you should have the surgeon show you the MRI, show you the nerve, show you the vessel on the nerve, and say, this is what I think is causing the problem, and this is what I'm going to treat. And not saying, okay, I'm going to do some kind of exploration. They got to see it before they deal with it. So I'm hoping whoever she does see can show her exactly what it is that they see and why, and go ahead and take care of her. But this is a good position, so I wish you the best. Please let someone good take care of you.
Okay. Thank you so much. It is time to move on to the concluding session for the day. And as usual, this was a wonderful presentation.
Thank you, Ann. Thank you for all those good questions. And if the people can write notes and tell me about those other things that they've noticed in themselves, I'd love to hear about them.
Oh, that's great. That would be wonderful.
I hope this is the beginning of a whole different look at people with trigeminal nerve pain.
Yeah. Okay, thank you.
Thank you.
We'll see you all in the concluding session.